I'm from Apex Orthopedic Rehab right here in Wyckoff. We're just going to go over a little workshop. Our goal here for everyone is just to educate. You know, the more you know about your back, and the more we understand, could you tell us about your unique problem, the better we can help you. So we really always want to understand. We do a lot of talking when we first meet everyone here about how they came to. What's your story? Like what really started this, and because you understand your back that day to day and understand what's good for it, what's bad for it. So that's really important. It's really education. So and understanding the patient, really listen to the patient. So anyway, so we're just going to go over a little. What we're going to start with. So anything low back pain and sciatica. I use the McKenzie method approach. It's basically just a particular way of evaluating the spine, but we use parts of it and we kind of build from that. We do some other things that the literature has shown that really help people with chronic low back pain and an acute episode, like an episode you just had it happen, you've never had one before, or something that keeps on coming back, which is pretty common. And basically, what's a good informed decision for your back? What's really good for you? What's the steps to take, not to get alarmed about things, but understand this is going to be all right. I can do this or this. Because it's scary. I had 2 episodes of back pain, and it was like I was just shut down. I couldn't get into my Suburban. I could barely turn my head in there. It kind of told me a lot about what must be going on when this happens all the time, or you have it chronically. So, and we'll talk about a little bit about how to make an informed decision. Facts and fiction. There's a lot of stuff that unfortunately is out there that's not really accurate. And a lot of people just kind of say it. You hear it as mantras, and it's not really accurate. I'll talk about some of those things a little bit. I understand how the method is used here and how we start. I always said this method may not work for you, but we'll know pretty soon because it's a very simple plan. We have a very systematic way of taking you through it, so you kind of learn from it. Some people are non-responders, some people are slow responders, some people are fast responders. Those are the ones that are really fun. People can kind of really make a big turn. And then a couple tips on prevention. So some of the big risk factors is having a previous episode of it. Unfortunately, there's a high percentage of coming back worse. So we really want to understand how can we prevent that second episode? What can we do to kind of catch that before we get that and learn how to manage it? We have some early signs that are telling us something's going on. Smoking is a big issue, especially for the disc area. So the disc is a part of our back. You can see on this guy right here. It's a little spongy portion. We'll talk about this a little bit more. In between here. And this disc right here has these small little blood vessels to it that are really affected by smoking. So if you are, some surgeons will say, I'm not going to do surgery until you stop smoking. You got to kind of stop that because it affects that healing in that area. So we have to be really careful about that. So proactively not, and then also if you're recovering, be a great time to try and set the best environment for healing. So, obesity, just mechanically. People say, well, if I lose weight, will my back pain go away? I'm like, a lot of good things will happen if you lose some weight. So even if it doesn't solve your back pain, let's kind of embrace that for general, feeling better, cardiovascular, and just there's so many benefits for us kind of doing that. Mom and dad. So you can blame mom and dad. One of the risk factors, if mom and dad have back problems, you might. There's just a genetic kind of linkage there. Doesn't mean you can't improve or get better. It's just there is a little connection that we're seeing there that you can blame your mom or your dad more, or grandpa. I'm not sure.
Another thing?
There you go, man.
Another thing, right? It's on top of it all. I'm getting told a lot of things that I'm, unfortunately, giving my kids. But heavy physical work, unfortunately, really heavy work. You'll see this in the powerlifting. Most people are doing really high loads. They definitely have a little more wear and tear, which kind of makes sense. Carpenters, laborers, it's just a little bit more demands in time and just. They can adapt sometimes, but they're typically very strong, but can have some real difficulties. Frequent bending, just repeated flexion, just repetitive flexioning and turning is unfortunately just something that's part of your. I was making hot dogs at the Roundco game, and I was over this grill, and I was loading them, and I was trying to do the buns and all that, and I could see how that was part of your work, would be kind of hard. You might be able to develop some resilience to it, but it's definitely something that's a little bit difficult. Static postures, any particular posture that you're in for a long time. It can be even standing. Like they say, used to be like standing desks are dependent, that'll cure everything. Well, just standing isn't great either. Sitting, you kind of want to be I call the ADD person. You want to be moving, and I love my job because I'm always kind of sitting with people, and then I'm talking, and I'm moving, and I'm leaning, and I'm back, and I'm always kind of moving around. And I think that's really the key. They have there's a big initiative in California with this one guy, Kelly Starrett, who's a therapist. and he's talking about these standing desks for kids, so they can move and fidget and they can sit. It allows, especially with the hyperactivity, they're not penalized for moving around. So I think it was kind of cool. But they can sit, they can do all sorts of things. So poor work ergonomics, just things that aren't set up optimally. Lack of physical activity is probably one of the bigger things that we talk about. And excessive twisting, excessive lifting, which is kind of part of the other ones. But yeah, big thing I try and promote with anyone here is just getting a little more physically active. Certain people that are very active, yeah, they're not in that category. There's a lot of people that I just want them to move a little bit each day. I'll say, go get a dog or just do something. We want to get a little bit of even low level activity, and that can really break some of our cycles. It depends on the person. I know, John, you're very active in biking and all that, so you're not that candidate. That's something else maybe. But that's something that we want to consider just a little bit. Even if we do it some people say, I can only walk 5 or 10 minutes. If you can do it 3 times a day, just little walks, it kind of spreads it out. It also really regulates blood pressure really well and things like that when you do the little walks throughout the day compared to all at once. So a big thing people ask about is red flags. When I say red flag, it means don't go to me, go to the ER or go to a physician. And there's very few, but there's very serious ones. If you're having weakness, I don't mean because you haven't worked out. All of a sudden you're like, it's kind of weak. I'm getting a little, or I can't lift this up, something, and it's getting fat, and it's getting weak fast. You'll see it over the course of a few days or even a couple of weeks. You're like, I'm just not moving right. That might be a sign you have a nerve root that's really, really compressed, and we want to take care of that. You want to take care of that quickly, because sometimes the strength doesn't come back. You may need a quick epidural. You may need something quick to take care of. Same thing with bowel and bladder function. If you have difficulty having a bowel movement, or you're having incontinence or pain on yourself, quite frankly, that could mean that some nerve roots are really affected, and you want to take care of that within 24 to 48 hours. It's very rare, but it does happen, and you just don't want to live with it. And I don't mean you're having something that's long-standing and acute, all of a sudden something changed. All right. Sudden onset of balance problems. Fever, if you had a recent surgery, sometimes you're dealing with an infection and it's kind of moved to your back or something like that. You should be aware you had some kind of thoracic surgery. You've got to be aware that fever is a sign of maybe an infection. That can cause some serious problems. Unexplained weight loss. I call it the I wish question. I wish. I say, hey, do you have an unexplained weight loss? No, I wish. And that could be a sign of cancer, something more sinister, so we want to be aware of that. If you had a recent trauma, if you have someone come in, if someone comes in and said, you can come to a therapist here, actually in the United States, without a physician referral, except for Medicare, workman's comp, and motor vehicle. But so people come to us and they say, well, I had to fall down the stairs, I kind of wrenched my back, and I'll go, well, let's probably get a basic x-ray, especially if we've had a trauma. And one thing we have to consider, this is very important, I would say plus 50, plus 60, especially among women, is we may have some osteopenia or bone density issues. So they don't need a big trauma to cause a fracture. So we want to be really aware of that. It may not, sometimes it's just coming off of a step, they'll get a fracture, and you think it's small, because you're like, well, why would I get hurt? The bone density issue is a real quick fracture. We want to be respectful of that, but that might be going on. And the last one is severe and constant night pain. I'm talking pain that's awful, mind-blowing. And that could be a sign of, say, something more sinister, a really significant infection, cancer, something like that. We want to kind of really note that and make sure we look for help quickly. That's some of the major ones. There's a few other ones there, but that's some of the ones where you really have to. After that, it's not as clear and it's not as immediate, you have to do it. You have some saddle anesthesia, numbness in this region and around the anus there. Pain below the knee, and history of cancer. So that's kind of, we covered some of those already. So the sciatic nerve, or sciatica, is the longest nerve in the body. Sciatica is really just a symptom. It's not really a disorder. It's just saying that something is affected that's causing pain down the leg. Most times it's towards the rear and often extending down to the foot. And some of the lower nerve roots that are actually are affected are more in the lower lumbar spine. So these nerve roots are passing real close to where we have a lot of herniations or problems in our lower back, or inflammation. So when that occurs, the nerve roots, as it's going down, all these roots go down to the leg. They're affected by inflammation or disc protrusion or some kind of scar tissue and such. So you'll get this sciatica term, but it doesn't tell us a lot. It doesn't tell us what it's from. Diagnosed, Sciatica truly, if you're really doing a diagnosis in the clinic, there's certain tests we'll do to say, okay, we're reproducing this symptom. It seems like it's sciatica. True diagnosis is a nerve conduction test where they actually put electrodes to your different nerves and they see how fast is that nerve conducting. And if it's supposed to conduct, let's say, at 50 miles per hour, it'll actually conduct at 40 and tells us, ooh, that nerve is not functioning. Where is it affected? And it'll tell you where in the chain. Most times it's right on the lower back, where it's actually affecting. It can cause weakness or sensation changes or pain. But that's called a nerve conduction study. And that's truly, if you're going to diagnose a serious nerve issue, not transient, it's something more long-standing. What else? Does it get better on its own? Except for about 10%, a lot of this will get better within 6 to 8 weeks, even if you don't come to me. I would say as a new therapist, I probably prolonged a few people's recovery because I overtreated. Sometimes we have to kind of listen, not really get a simple plan. And that's where the McKenzie system is typically 1 or 2 exercises at the start. And if you do too much, it's related to that or something else they're doing. But a lot of them will get better with time. Unfortunately, this 10% gets massive disability. They have injections. They're the ones that are going for surgery. So the whole idea is that if we can manage it better, educate you at least on things in the early stages, we can ride out that cycle and hopefully feel a little bit better. But that 10% is a tremendous impact on society, on people. So it does create some problems. It just shows just some quick, I'm not going to spend a lot of time on this, some of the nerve roots coming off the lower back here, and they go as a bundle. So each level, as you look here, where these nerve roots come off of here, I'm not sure if I can turn the lights off, but these disc areas, these 2 discs right here, L4, L5, and L5, S1 means sacrum 1. And this is where most likely we have a lot of these herniations or disc problems. We'll talk a little bit about that later on, but they can affect inflammation or mechanically can lean on some of these nerve roots as they go down. And that's our common area. You can have other problems higher up in the spine. This is where a lot of our problems come from, in these 2 segments. And one of the ideas is it's one of the most mobile segments. It contributes a lot to our flexion extension, so it gets a lot of kind of wear and tear in that region more than other ones in the lower back. That's the nerve root. And it's really a compilation of a few different nerve roots that feed into one. There's a little picture of the spine. Everyone thinks it's a straight spine. It's really almost like a spring. You look at this mechanism right here. It just it compresses like a spring here. Okay, and it's supposed to kind of take loads and be like a shock absorber right now. But this is the area where we're seeing most of our problems are. This is the lumbar disc. Everyone talks about the disc. We talk about the disc because it's one of the main contributors to sciatica or lower back problems. It's by no means the only thing, but it's one of the big culprits. Okay, this is just the outer annular rings, and this is the nucleus right here. This is depicting a herniation, so a portion of the nucleus slowly gets displaced out. In the early stages, you may not even feel it. Typically, people feel it as it gets further out to the very outer rings right here. Typically, it goes, I cut myself in half. It goes to the back or to the sides. It goes to the sides, it gets close to those nerve roots we were talking about. As they exit, they go real close to where these herniations occur. That's why they're so significant. We don't typically get as many herniations forward. It's a very low percent, I think 1 to 3%. Some go straight back, but this is one that's going off this side, and that's where that nerve root is. And you'll have someone that'll have symptoms just on one side. If you have symptoms down the center, sometimes you're actually you'll notice you'll get bilateral, you get symptoms on both sides. But more commonly, it's more off to the side. And sometimes they even appear like they're kind of shifted to one side. Typically, if the symptoms are here, they'll be shifted away from that side. Is it mechanical or inflammation? So someone that comes to me and says, I've got this back issue, I'm taking Advil, it really doesn't make a difference. It might be that herniated material, which is like a physical, it's like me stepping on a nerve, is there. So it's not inflammation, it's not chemical, meaning they have this fluid in there it's irritating the nerve. It's actually mechanical. So they'll say, Advil doesn't work, just doesn't take my pain away, it doesn't do anything. The ones that say that, you can have a lot of inflammation around those herniations, and that's the source of the problem. Inflammation, nerves hate inflammation. It actually affects the way the nerve conducts, okay? So as we drop the inflammation, people feel better right away, like, oh wow, I'm a lot better. I took that Advil, or sometimes I do a steroid pack, like a Medrol pack, and they feel better right away. That's a lot of inflammation that's causing it. That's very irritating to the nerve. If it's mechanical, they may benefit from more stretching, strengthening, and things like that. That's really their solution to the problem. I have people that I take them here and I move them everywhere, and they go, "This is getting better, Tom. If anything, it's aggravating me." I say, well, we might need like steroids, maybe more anti-inflammatories, or rest or modified rest. We want to let that body heal somehow and drop the inflammation down. So we have to kind of look at that. I think with the spine, it's if you look at a joint, like say a finger joint here, you can see it's swollen. To stretch it constantly is probably not the solution to it. Same thing with back. So once the inflammation's gone down, then we want to, it may still be a little bit tight. That's where that mechanical, the right stretches for it will make it feel better. It's kind of like that cut on your knuckle. As soon as it's cut, well, let's open it up by stretching it. Sometimes that's not what you want to do initially. Sometimes it is. If it's more mechanical, you could stretch it the first day. But it's inflammatory. Stretching sometimes is not the thing you want to do right away. So, if I'm talking too fast or you have questions, just raise your hand, and I'd love to hear someone else talk besides me. My kids will tell that me all the time. Dad, you're talking too much. So back pain fiction. MRI and x-rays are needed prior to starting to evaluating a patient for back pain. Not actually, they'll actually say don't do it unless you have certain problems like we talked about earlier. The concern is that when you see this image, a lot of us have these things in our back that are herniations and problems, and we get scared, we get nervous when we see it on MRI, so we go, ooh, that herniation's there. It might have been there for years, actually, because a lot of people have these on MRI and don't have symptoms. So they'll say, wait at least 6 to 8 weeks before we jump to it. If they aren't improving, maybe at 6 to 8 weeks we'll start doing it, unless we see some signs of weakness or something that's we're really concerned about. Even an x-ray, people go, I got a degenerative disc, I can't move, I'm going to break something. And they almost become more fragile. So we don't want to, but listen, it's not saying we shouldn't do an MRI, it's just we have to make sure we kind of be a little bit careful about reflexively doing it. So, another fiction is bed rest is often the key to feeling better. I would say bed rest after 3 days, they show that people actually get worse. So you want to get out and move a little bit once you feel, and I'm not saying you got to go for a jog, I'm saying you've got to just move a little bit, make dinner, sit back down, try and slowly move as much as you can without really setting yourself back. It's really important to move. They found a lot of this stuff on rest came from, believe it or not, from my kids hate this because I talk about the history of it. I think World War II, when a lot of people were being evacuated out, and they had some people that they couldn't put them in an ambulance. So the ones that had to walk more, they actually did better than the ones with the same condition that got, the gurney, and they were totally taken care of. And I go, wow, maybe complete rest isn't great. Maybe we should make them move a little bit. So patients always go after certain surgeries, get me out of my bed, there's an insurance thing, they're trying to get rid of me. Well, no, they're trying to get you moving a little bit because you're going to recover faster. Blood clots, all sorts of other things. So yeah, rest is good. I call it modified rest, is really what I like to say. MRIs can't see pain. You've got a lot of genes in MRI, but you can't say that disc is the origin of pain. It's part of the picture. If that level corresponds to a clinical exam and what you tell the practitioner, then we can say, okay, that makes sense. All these pictures come together. I can't tell you how many people I've had that said, I have a herniated disc on my right, my MRI. I go, great. He goes, all on your right. And they go, where's your symptoms? It's all on the left. I'm like, so you kind of have to look at it as a piece of the puzzle. And with the portals and people getting access to MRIs, they get really nervous because they see them before the doctor can explain this to a physician, and they go, "Oh my God, I saw this in my portal," and it creates some problems for them. So I'm not saying it's not important. I'm just saying it has to be in context of what you're doing. Someone said it's kind of like trying to see who's drunk at a wedding based upon a photograph. You really can't tell. You kind of have to be there and understand the nuances. Screening by a physician is necessary before starting a course of therapy. I'm nothing against physicians, and I'm not trying to beat it up, but we do a very comprehensive screen for that, and then we decide, hey, this sounds like something we need blood work, and we're not saying the physician isn't part of the process, but should be part of the team, as far as making a decision. Sometimes they go, you need blood work. This sounds like this isn't mechanical. This doesn't sound like something. We need to have another eye on this, and I'll refer out to people all the time. This is something I just read a great review on. Can exercise reduce pain? There's some great evidence for, especially cardiovascular exercise, walking, swimming, elliptical, and some strength training that'll actually decrease your perception of pain centrally. Like your brain doesn't register as much pain based upon even like one bout of exercise can cause a reduction in your appreciation of pain. So if you can get someone to move a little bit, that person is constantly shutting down, I'm not going to do it, it's got to be completely pain-free, they actually don't do as well. And the biggest thing is finding that tipping point of too much that tips them over the edge, but just enough that kind of challenges and causes that central, almost like desensitization. So what I say if I have someone that comes in here, let's say they're from Texas and they came from the same, my uncle called me and goes, what do I do with this? Like, just start walking a little bit or do a little bit of movement. Because some of the thing is central, meaning it's here. It's not the tissues being damaged, it's the brain. The brain is that, and it decreases that sensitization and really can help you. But if you do too much, then it can go the opposite way. We all of a sudden create more sensitization. So the key is to figure out the right dose. Give a little bit. So I start out very conservative. I go write down how long or how many steps it even be in a day. I'll say, tell me how steps. Well, I get to 8,000 steps. That's when I start having problems. All right, let's try to do around 6,000 to 7,000 steps for walking or just general activity. Unless they go to Disney and they get 20,000 steps. Mm-hmm. But they always feel better because they're in one magical place. But we do want to consider this as a general strategy. That's why we don't want them to shut down. So the first few years after graduating, I kind of, every time I would go to a continuing ed course, I'd get excited for my new tool, and I'd use it in the clinic. And then I'd come back, and then I get another tool from another continuing ed class, and I would kind of do it and use it. And it was kind of like the flavor of the day. The McKenzie method has been really taught me more of a structure and a starting point. By no means the whole thing, like these things as far as exercise helping with pain is not included in that particular formula. So, it's definitely created more of a formula and more something that I can learn from. So it's really helped me, and it's just a very simple, good system. But I had talked about this a little bit. My visits, I typically know pretty early on if they're going to be a slow responder, non-responder. Not absolute, but I kind of know very early on with this particular system, within 2 or 3 visits, what I have and what we need to do and all that. But it's really the power of one exercise. We kind of know, we give you 1 or 2 exercises in the start to try, and then from there we kind of build on that once we get a little bit of pain control. So, keep me excited, I got another patient. And by no means, listen, this is an approach, it's no means, there's so many factors that go in back issues. It can be stress, it can be sleep, it could be nutrition. I used to have a guy that was a pipe fitter, and he said I was always in pain at work, but then he did the same work, he went on vacation, he felt great. And I said, oh, it must have been the pipe fitting. And then when he retired, he everything got better, everything got better. I'm like, how did this all get better? And for him, it was a big stress component. Mother-in-law comes over. This one guy said, you're right, every time mother-in-law comes over, that weekend is a very stressful weekend. I never saw the correlation, but every other weekend she'd come, and it was I'm not saying that's it, but the mind is a big part of that. If we can manage stress and figure out those things, that's a big part of it. And not for everyone. It's like which factor has got the greatest weight. Some people it's stress, some people it's sleep, sometimes it's weakness, sometimes it's lost emotion and mobility. So at the end of it, we find, I think I kind of went through this one already. Yeah, basically learn from the system, the McKenzie method, and we kind of learn from what works and what doesn't, because we're typically prescribing one exercise at the start. So if we don't see a response pretty quickly, we'll change the exercise and movement, and then make a change or refer back out. It really classifies patients based on movement. So we're taking the baseline of certain movements. We see where their baseline is. And then we'll say, okay, based upon your response, whether the pain gets better or worse, we'll have you do a particular movement. One of the common movements is a lower back stretch like this. Some people refer to the old man stretch. I can say that now because I'm 56, but moving back like this. That's one of the common ones, but it's really based upon how the patient responds to the movement. It's very personalized to the person. I have some people, I arch them back and they want to slap me. They're like, that hurts. And then we know that's not an appropriate movement. We also know there's certain exercises that are probably not appropriate for them, based upon that movement strategy. Some people are just very intolerant of going forward with this. It really depends on the patient. And basically, once we take you through that eval, we'll know which movement is good for you. Believe it or not, some people reduce back pain by doing a side shift motion. It really depends on how they respond, and we track that in the initial evaluation and establish, is there a directional preference? Is it a preference that you seem to prefer and feel better? That's what we look at. If they don't, It could be inflammation. It could be, hey, this person's not it's not that they have any loss of motion, but it's not a mobility issue. We got to get them stronger. We're going to see if we can work on the strengthening and certain things like that. Naturally, the solution to their problem. It's not a mobility issue. Well, we always start out with mobility. Let's see, that's the first kind of the bottom of the pyramid. Let's see if we can see if that's the issue first, and then we move from there. One other thing, has anyone heard the McKenzie method? You've been around me for a while, so you've heard, okay. The McKenzie method initially was thought about as the disc model, that when we moved in a certain way, we move that disc material around. And if we move it around, we move it to the center, we take it off the nerve root, it feels better. That's the theory behind it. But depending on the person's back, the disc, they've shown studies where it moves, when you extend, it actually moves more on the nerve, and other studies it moves off of it. That's why it's based upon how you respond to the movement, not how we think the disc is moving. It's really based on the movement. We think sometimes we're moving that nuclear disc material off the nerve root, and it's mechanical. We're taking that pressure on the nerve root and offsetting it. But we really honestly don't know absolutely. We don't, so we have to kind of go by, hey, what feels better? Some people feel better with flexion. They say, I feel better when I reach forward, and I've done this for 2 or 3 days, and my back is feeling better. Different type of problem. So don't get caught up. A lot of people think about the disc and all that. I just use that as a model of like understanding it, but that's not, it's really based upon the movement that makes you feel better. So does posture matter? So there's whole debate in the rehab community, and they'll beat around forever. They'll say posture doesn't have any connection to pain. Other people's posture definitely has a connection to pain. I think you have to go by the person. If you have someone that's very tight for years, if he's like 60 or 70, he's been working in IT for years, he's lost the mobility to stand up. To get perfect posture for him actually makes him feel worse if he doesn't have enough range of motion or the stamina to do it. So forcing that movement, sometimes it's not great. Sometimes what I want is someone to kind of get into that comfortable in-between phase, that they're comfortable and not stressed. Sometimes it does make a difference. I get people lumbar rolls and little supports for the lower back all the time and say, this feels better. But sometimes I give them the rolls and they said, that roll's too big. I got a little smaller. That was too much of a correction. So you kind of have to make it for the person. There's no consensus that what's the perfect posture. Like some people feel like this is, what's the position in the back? Like, and it can be very anxiety producing. So I always tell people posture has an influence, just like anything, especially in the acute phase. If you have I think of posture too in the acute phase. If you have a cut on your knuckle, we'd want to maybe brace it. Let's say we had a ligament dam, something more significant. We want to brace it a while so it scars down, but eventually we want to start moving it. So we want to protect it maybe with good posture for a little while, but eventually we want to kind of move it around a little bit. We want to be a little fidgety. We want to change our posture. I think there's certain things that are better, like your breathe. You take someone and have them come over like this and have them breathe in. That posture influences their ability to breathe. Sometimes it affects how resilient they are lifting something up. So I do think posture with lifting or position can make an influence, but it's part of an overall picture, and we have to look at it as a piece, okay? Because it can be very anxiety producing. I have a lot of people say, I have crappy posture. In fact, I've never had anyone come to me and say, I have great posture, and it's not always correlated to pain. Sometimes it is. Sometimes it is. I think we have to be more open and not rigid about how we look at this. I always say this, does posture matter? It depends. I mean, I kind of like just kind of changing, like we talked about earlier, just moving around and switching postures and varying our positions, slumping, sliding, just kind of moving around. I met this guy, and he looked at his posture, and he was bent over and turned, and he said, he was a barber right over in Fort Lee. And his wife was with him, and I said, wow, this is the first year out, posture's bad, he's over, and is that from poor posture? And I said, has he been there for a long time? Was he standing up a month ago, or is this something because of a herniation or something? His wife he's had pain for a month, but he's looked like that for years. And I was like, okay, I think he was cutting hair like this for absolutely 30, 40 years. Nicest guy in the world. I was like, I feel a little bit of pain. He came there, he did well, didn't do great. But I don't think his posture, his movements, it wasn't that he had poor posture. He'd always been in position for years, and I don't know if it was acquired, scoliotic, whatever, but he's functioned for 40 years, and this is the first episode back. So I'm like, all right. So I just call it the story of the barber, but really nice guy, very upbeat, I'm like, actually, it's telling me the power's down on this. Sorry, guys. I'm a big research guy. But I don't think research always shows everything. I think we have to really look at beyond, we have to be practitioners and trainers and say, what fits this person, what makes sense for this, and really apply it to that person. I think it has a big impact. Sometimes it's not the issue. Sometimes it's actually an outgrowth of feeling. Some people adopt certain postures. It's an emotional thing. They say, they're protective, or they're not feeling stable, or secure or confident. And as they work out, actually, they get more confident. Their whole disposition changes, and they have. And I think all of a sudden they're standing up and they're feeling better about themselves. And it's an emotional thing. Even it's not really related to mechanical. So, real quick, I'm not going to talk too much about this, but basically when we do our evaluation, we take a big history. As my ex-professor at Miami told me, history. That's the most important part of the evaluation, is really how they're coming here, what their story is, how long they've had this problem. You got to know this person. You got to spend a ton of time talking to them. I just let the patient talk, and when I'm really good, I try not to talk for 5 minutes or ask a question. I just want them just to talk to me and tell them what they think is important. Tell me your story, okay? So if you're ever getting care, even if it's not from me, tell your story. Make sure you educate them. Talk things that make it worse, things that really bother you. Are you fearful of movement? Are you fearful? You gotta talk to them. How did it start? It fell down the stairs. It came out suddenly. You want to know really what their fears and things are. We check. This is kind of technical stuff, but this is just talking about understanding some baselines as far as how far they're moving, reflexes, are there any weakness, how they move, how they feel when they move in certain directions. I have people tell me, I did this stretch, it felt great. I'm like, let's just try that a little longer, especially if I don't see something in the evaluation. I'm like, let's do that a little bit more consistent. A lot of times we have folks that do certain movements, but they do it a little bit, and they just have to do it a little bit more, and they do it more consistently, even if it's not exactly what you need, and all of a sudden they get better. They're just kind of going through YouTube. And listen, I have a YouTube channel, and they pick all these little things, and nothing seems to work, and they're kind of confused. So we're trying to find the best movement that kind of makes them feel better or worse. One thing with the evaluation too is, especially if someone that's very fearful or we're not sure, like it looks like this is going to be the right movement for them, we'll tell them we won't do hands-on stretching the first time, because if it's going to really bother them, they'll stop. If they're doing it themselves and doing the stretch, they'll know when they have to stop. If I go in there and start stretching the first evaluation, sometimes I will. Sometimes I just amplify a problem that I didn't know was going to be a problem until they started doing that movement more. So they'll say, why didn't you stretch me? Well, let's see how you do it, and then I'll stretch, and this stretch will kind of help you with the stretch that I'm giving you. Postural stretch, okay. Basically we're just talking about, we're going through loading strategies, basically repeated movements in a particular direction. So I'll have someone go through the motion, a series 10, 20 times before I determine that that's the right movement. And depending on there's a progression. I typically do things in standing, then I'll do things lying down. Depends on the person. I'll give them some postural instructions, like let's avoid this. I think for you, like I said, it's not that I ignore posture, but I kind of say, well, this is something, this movement or position I want you to avoid. It seems like it's going to bother you. I'll give a couple things on back school. There's all this. It's funny, you look at, certain people are saying lifting techniques don't work. You can develop resilience. I kind of feel like, let's find a technique that works for them for what they're doing. If they're having trouble doing a squat and really want to do it, see if we can modify it to make it comfortable for them. Okay, or it could be let's say, John, you're a biker. A bike setup. Maybe sometimes dropping the post or change the geometry of the bike just fits their body type, and that's what we have to do. And that's kind of posture and those things. Spinal stabilization techniques. That can be very powerful. There's a symbol called the McGill 3, which is a professor named Stuart McGill, and he talks about spinal stabilization a lot. And they have some basic ones you can do every day. It becomes this kind of mantra. And I'll add that typically after we go through, is there any mobility issues? Then we'll go towards stabilization. And I always want a little conditioning endurance work, even if it just helps them with just decreasing that pain signal a little bit. When we are doing the treatment here, a little discomfort that goes away, I'm not too worried about. I'll say if you work through that, you're most likely going to progress faster. If everything's pain-free, first of all, you're going to be fearful when you do experience it. I want you to realize that some of it is normal, just exercise, and as you desensitize by going into that little painful range and then stepping back, you're going to recover faster, and you're going to become less fearful of those experiences. So it's important. Most people have some discomfort when they're here and when they're doing exercise. But I try not to, and I really ask them what's good and bad pain. We go through a lot of and that's really important to understand that. Because then when they do things on their own, they're like, oh, I felt this before. I'll be all right. I can do a little bit, but maybe not too much. Maybe I'll do 15 minutes of yard work, not 30. Kind of at that point where that's going to be problems later on. And they're going to feel better, and they're going to feel more confident. And they're going to enjoy life. That's the thing. We want them to be as active as we can from a social, psychological standpoint. This is one of the common exercises we give out. And quite frankly, why we give this one out more? Because most people are sitting forward. We lose this motion. We don't have a lot of people walking around like this. Okay? A lot of our work is forward or neutral. That's why it's more common. But I still give out a knees to chest exercise. I will do other exercises, like I said, for them. But this is a standing extension. This is one of the ones just we give out a lot. And he's a little tight. He definitely, he's probably a little tight there, probably a little more motion. Problem with the spine is we only have one spine. That's good and bad, I guess. We don't have a comparison, let's say shoulder mobility compared to the opposite side. So we kind of don't know, what's the limitation structurally? Because some people we have some people like dancers, they'll almost go 90 degrees here. So we almost don't know if they have a motion loss until we try and work on it for a little while. I had a dancer once that literally, I had her on the table, and she was literally almost at 90. And then she go, oh my God, that feels so much better when I'm at that very end. But I thought she had reached the end earlier. But she just was very, very mobile. So it's very, very interesting. That's one of the ones we commonly give out. And this is probably the second, prone press up or cobra. What I like is when someone benefits from this one, they can do it anywhere. For someone to lay out at work, as between Zoom calls, this doesn't happen as often. So I love when I have someone who responds to the first one. They do well with this one. I say, do this before you go to work, or maybe when you come home. Try this one, and we'll see, especially if they respond to that. A few people don't like one or the other. You only can do one or the other. Most people can do both without having a problem. That's just forward flexion. This is maybe our folks that have stenosis or a certain type of back problem. Those are folks that are in the shop, right, and they're walking around on a cart or whatever. They really like to be forward. They don't want to be upright. And they're making room for that nerve root so the nerve isn't irritated. Knees to chest. Standing flexion. And these are the movements we pick out one of these, maybe two the most, before we. Then there's other ones. You'll see folks that are walking and they can't do that correction themselves. So this is hug and love your patient. I'll do some manual corrections with them standing, and we'll try to correct it. I did this with my stepfather the day of my wedding. We went golfing, and he was walking down the golf course like this. So I hugged him a little bit, and we did some stretches and all that. So we do some hands-on stretching. Sometimes it's not the first visit, but we typically add that in pretty soon. Once they're stable, 5 to 7 days, we then have them, if they've been doing a lot of these, we test it out. So let's do some flexion. Let's do the opposite direction and see how stable you are. Sometimes this isn't done. People kind of say, well, I'll work it on my own. And then we'll try to see, if they start going the other directions of motion. You want to stretch everywhere. You shouldn't, if it's really healed, you should stretch this way. Your body's meant to go forward in addition to backwards. We'll test those directions and see, hey, is this person stable? Okay, good. We can give them these exercises to do on their own. We've cleared them. So that's what I'll do at the end, depending on the person. So, and then also, before they leave, it's what can I do? If I have this flare up, most times the exercise that helped them the first time, that's typically the exercise that helps them the next time. So I'll say, hey, you start feeling like the back's getting a little achy, whatever, jump out quickly. Do the one that you did early on, and then let's get you back, and let's pull back on a couple of things that are more intense activities that may have contributed to it. And then you catch it early, it's just easier to manage. All right, I'm not even going to go centralization, I'll explain something else. All right, so there's a big chance of recurrence. We really want to kind of figure out, like we talked about, what are the early signs of this coming back, and can we figure out what our triggers are? It's that longer bike ride, it's that long drive to the shore. Can we break up things? Can we understand how my back acts? That's probably the most important thing. But self-management, if it is, you really can achieve it if you've had it before and you understand your back. So I would say one of the few things I'll talk about a walking program, at least 30 minutes a day, based on just strengthening and also that pain control. I will make some workstation changes, some things that are extreme. Like I said, we'll maybe modify a few things we're doing at home. or even change the monitor height, just kind of vary a little bit. Get an eye examination. Sometimes people are craning forward on that computer, and it's really not a physical thing, it's just they're accommodating for some visual issues. My wife had some extreme headaches, and the doctor told her, I think I've told this story, but I'll tell it again, went through a whole screen for a neurologist, and I said, I'm getting these horrible headaches, and the doctor's like, well, I don't see anything wrong with you. He's like, well, give up, coffee, red wine, and chocolate. She goes, you might as well kill me. He's like, well, I don't know what to do with you, man. Like, you came to me, I got 3 boys, and gosh, I need all those. He goes, well, get an eye examination. She's like, I don't need eyes. Eyes are fine. Gets an eye examination. And believe it or not, the headaches went away after she got a right prescription. She was sitting up taller at a desk. And anyway, there's other reasons that contribute to problems. So that's a good example. There's other things we have to look at for any condition. And then understand the triggers for your pain. And inflammatory diet is definitely something that is worth exploring just for general health. But high sugar content, things like that, obviously those are not great for healing. I swear my knee seems to react to that when it's Halloween. And I just feel like I was like, oh wow, there's a couple of treats left. And every time I go past the bucket in the last week, I swear my knee gets worse with that. I don't know if it's true. Darn, it seems like there's some connection there. I don't know, everything feels a little more creaky, but you gotta find your own way. Okay, so we talked about that top exercise I give out is a lumbar, like I said, standing lumbar extension, or prone, or the lateral glide. I typically tell people, one of the big things people say is that I've tried an exercise like this before, but it didn't make a difference. What they have to do is they have to do it longer. They have to do it I have people do like 10 times every 2 hours, like throughout the day for like about 5 sessions for at least a week before I say, this isn't working. It's really a frequency issue. And I'll tell them, get up, move around when you're sitting, change your body position, and walk. Those are the 3 things I'll tell people. The lateral glide, which is this particular motion, is probably 10%. It's just not that common. If I do give out a lateral glide, typically if patients, they don't necessarily look crooked. They may just feel like they have symptoms on one side. If it's the painful side, that's the side that I'll push on, okay? So my trunk is going towards that side if that one works. But that's very hard to determine, and you can really kind of irritate your back if it's not appropriate for you. So you gotta be a little careful about trying this one. These two, if you kind of listen to your symptoms, you can really typically be neutral or better. But certain back conditions can be made worse by doing these particular exercises. They'll get really angry at you. So you got to gradually kind of listen to how your back reacts to it. So if you want to start here, basically private insurance, you don't need a prescription. We talked about this earlier. You can sign up for evaluation. Medicare, most doctors, if you want to do movement and exercise, they're all for it to try and do natural approaches to care. So they'll write a prescription for you if you have a good relationship. Sometimes you see a specialist, you have a complicated situation, especially if you're having weakness or some of those other things where you're not sure about it or it's very sensitive. Sometimes they say, let's see the orthopedist, let's see a spine specialist. If you're not going to see someone that does just a lot of spine. There's a lot of PAs that are working with doctors. Sometimes you don't get to that person until a second step. But there's a lot of great doctors out there and some great PAs that if they see a lot of that, they can help you just as much. That's about it. And that's the oldest picture. I'm a family member. But that's we have to get an updated one. 2 were in college, so I got that's true.
That's a real old picture. That's a real old picture.
Yeah, you gotta do it. Any questions on anything about any? Yeah.
I got a question about the lateral glide. As a person with scoliosis, is that something that's helpful?
It can be. It can be. Sometimes even in the direction that actually you would think amplifies the glide. It matters really what the response is by the person.
Right.
But most times I do not go into the direction. If you're shifted one or you're I'll typically go the opposite way. But also, I may go by how the symptoms are. Sometimes they've had that curvature a while, and that's really not the origin of the problem. It can be. It just may be not the origin. I'll say I'll use that one more, especially if someone has an acute bout. And what you'll see is when you look at them, they'll have an extreme difference left to right. They'll go, wow, I can get to below my knee here, but I stop right about here. And they'll say, oh, my symptoms are all on this side. Then I'll typically try and do the lateral glide this way, the direction of restriction. Or if they're shifted, same idea. I'll basically try and do that. I'll try and make that correction. One thing with the lateral glide, Lynn, is that I always follow up. We correct this, because then typically there's still a range of motion loss this way. So we do 10 this way and 10 in extension. We always follow by trying to get a little extension, because commonly, once you correct this, there's still most people, there's still some loss of motion. Sometimes the lateral glide, all of a sudden, they're tight here, and they still can't go back. As soon as you correct the glide, they all of a sudden just gain it really quick. It's like they even have to work on it. But it varies. It's all dependent on the person, really. It's not absolute. That's why we track it on a sheet. We'll say, okay, patient responds to lateral glide, increased symptoms, decreased symptoms. One thing we'll talk about if you're doing any of these exercises at home, there's a phenomenon called centralization, peripheralization. Fancy word is, I'll give you an example, it's better. Okay, I've got sciatica down to the back of my leg right here, okay? It's here and here. Right now I've got the pain, okay? They're standing in front of you. Let's say they start doing the arch here. The pain then goes from here and now starts extending further down. They call that peripheralization, bad sign. We want to stop that motion. Let's say the pain is here, it's a level 5. I do this motion, it's still here, but now it's a 2 or a 3. But my back pain is worse. Keep on doing it. Okay, now it's up to here. Back pain's getting worse, but it's moving up. That's centralization. It's moving up. That's a sign that we're going in the right direction. We want to do more of that movement. The only problem about that is some people get scared because they'll say, this is a good example, you'll feel, I have just thigh pain here. I have no back pain. I don't know why you're talking about my back. Start moving the back. Oh, now I have back pain. And you're a real asshole. It's out of my leg. Now you gave me back pain. I remember I had a patient call me when I first started out, and they said, "Oh, by the way, Mr. Jones said you made his leg pain go away, but you gave him back pain." I go, and I got, of course, a new grad. I'm like, "Oh, what do I do?" My boss is there. I'm like, "Didn't hear that, did he?" And I get Mr. Jones, and I talk to him, and he goes, I go, no, that went away, but back pain started, but that leg pain's gone. I don't care about that. I want to know what you did you do here. Keep on doing that movement. And he did actually respond. I mean, listen, not everyone responds to the system. If anyone knows me, I shoot from the hip. Some people don't benefit, go someplace else. Get acupuncture, go whatever, whatever do. But this person did. But it's what they call, but sometimes you'll have isolated leg pain, and it's actually coming back, and there's no back pain. You'll see this at the neck too. I've had a few people with shoulder problems. They'll say, "Why do you keep on talking about my neck?" Because I always screen the neck and the shoulder. And it's sometimes even weakness. Like they'll literally look like a rotator cuff. They're like, "Oh, my arm is killing me. I don't have any neck pain." I go, we start moving the neck. Oh wow, that movement's getting better. And they say, my neck is kind of bothering me a little bit now. More and more, they improve motion. All of a sudden, that goes away. And sometimes it takes a couple weeks, but you'll see this connection. And I've seen this connection with spine-related problems. There's no spinal pain, but there's extremity pain. You'll see this with plantar fasciitis. Often people say, "I've got plantar fasciitis. I've got heel pain and foot pain." And say, "Doctor said I should do these stretches. I've been doing calf." You start moving their back. You're like, "Wow, that heel pain's going away." I'm not saying it's everyone. But there is this connection. They're noticing more and more that you don't have any spine-related pain, but you'll have extremity pain. It's actually coming from you. You would think you would have, if you've got a spine-related problem, you have pain in the spine. It doesn't always occur. It's like a heart attack in your jaw. I don't have any chest in there, but I have pain. Went to the dentist, and I don't have a tooth issue. This is coming from my heart. So you can have that referral pattern. So you have to be aware of that. That's why a good evaluation is important for that. And if you're struggling with an extremity issue, you could be dealing with a spinal issue. That's kind of beyond the talk of this talk. But just something. If you're struggling with a knee issue, sometimes it's related to something else that we're just not. And that's where the screen will come in. And that's why I typically screen the spine for neck and back. Even if I have someone knee pain, I'll say, "Let's check your spinal motion." I'll say, "Let's just part of wellness. Why don't we kind of give you some mobility as you work for your back?" Kind of like more of a holistic approach. That's kind of help. And what I do now more too is I'll also give people more of a holistic general strengthening mobility program. So we're working on this. Once we have control of this problem, let's give you like a general fitness. Let's just get you moving a little bit better in life. And I think that'll gain some confidence to just, everything gets a little bit better by, especially people that are very dormant, So like Rosemary, she's doing everything. You got to pull her back sometimes. So other people, I got to kick out of the couch, but it's some happy medium there. So, any questions, John? Do you have any questions?
No.
If you have any questions, we could talk about it private too. Yeah,
How do you feel about when somebody's in really bad pain, but it's not consistent, about a back brace?
I think, listen, my feeling is is that back braces sometimes make you feel more rigid, but I feel like try it. Like if you may need that brace and that comfort, even that confidence, I say wear it for a little while, but eventually you want to get away from that, you know? Like some of those double elastic Velcro braces, just go block that in. Let's kind of feel, let's get a little, if it allows them to walk a little bit and to do, like I'm also not against, like if you can't participate in care because you're in so much pain and you can't get strong, you can't do any mobility because there's, I say take an Advil. Like I'm not absolutely against that, but let's not rely on it. Let's just say, let's try, hey, well, they could actually participate in therapy, not therapy, just any kind of life more because they have a little less pain and that allows them to get past an episode. That's very important. Like don't be so rigid that you don't accept that. I think that's ridiculous. But if you can avoid it and maybe not use it as a vitamin every morning you take it, oh, let me see how I do today. Oh, that Advil really wasn't doing too much. I guess I could do more than I guess wasn't making an effect anymore. I mean, try it one day without. Especially the Advils and all those things are short acting, so you can try it and get away from it. Some meds, it takes 2 or 3 days for it to become more effective, so sometimes going in and out is not really, it's not the way to pursue. You kind of have to, I'll say, let's try 2 weeks of, and I can't recommend it, I'll say you have to talk to your doctor. Do 2 weeks, just turn your head off. I'm just going to try the med for 2 weeks, and in 2 weeks I'm going to stop the anti-inflammatory. And the doctors and I will talk about that, see how they do, or we shut them down, like they don't go to therapy for you, too sensitive. Let's give it a week. And we actually do rest. We don't do so. Go for a little walk. Let's see you in a week and see how you are. Too sensitive. Every time I try and stretch, everything makes it worse. I'm not the solution to your problem. You gotta be. You can't be, thinking that you're always a solution to this problem. Sometimes the solution is shut you down a little bit, and then come back. But that's what you're doing. Because rest is a 4-letter word.
Yeah,
So,
we know that.
Yeah. So listen, I'm the one that I tend to Sue's trying to put Advils in me when I'm like my knees bottom. I'm like, I don't want it. I can tolerate it. If it's affecting my sleep, I'll say all right, I'll take an Advil. I'll take an Aleve. But that's my big thing is if you're not getting a proper night's sleep, take an Advil. Do something for the short term to manage it. If you're not sleeping, I'm like obsessed with sleep now. I'm like. I got my little routine and all that. I go to bed, go upstairs 9:30. Why aren't you watching the game? I'm like, no, I'm going to bed. So, yeah. Anything else? Anyone else? Yeah. Okay. Well, thanks for coming. I wish we had a few more people here, but that's all right. I've got my crew here. I really appreciate you guys coming out. And if you have any questions afterwards, everything about a client, whatever, just pick my brain. We have discovery visits just to talk to people and give a sense of what we're about and what we offer. So, we have a YouTube channel. We talk a lot about this as far as different conditions and all that. You can always send them a link there. So thank you very much. All right, have a good one. Good stuff. All right. Great seeing you.